Good morning to all. We'll be starting with this session. I'm Dr. Mukta Sharma, and I would like to call on stage Dr. Diptesh Das.
Good morning, ma'am.
This is a case of iatrogenic zonular dialysis occurred during IOL implantation. A single piece IOL is being implanted. Suddenly, there is a sudden movement by patient, and the IOL is stuck in the main wound, and the jerk caused by it led to a large zonular dialysis. Anterior chamber is formed with viscoelastic substance, and viscoelastic substance is pushed in the bag to inflate it. The IOL is removed from the wound. I kept on inflating the bag with viscoelastic substance and also start assessing the amount of zonular dialysis. A capsular tension ring is tried. And about midway of inserting the CTR ring,
That I want to highlight here is the pupil is not very dilated at the present, and the 50% of the CTR was in, but there is some stretch line that appeared horizontally. if, uh, if 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 it was because of the stretching of the uh, CTR ring, it would have occurred longitudinally. And usually CTR does not stretch, it evenly stretches the back. So appearing of this signifies the probably the leading part of the CTR ring is out of the back.
I noticed horizontal fold appearing in the bag, suggesting the leading part of the ring is outside the capsular bag. So, I removed the CTR ring partially and reintroduced it.
This time no folds appeared. a single piece lens is placed in the bag. Alternatively, I could have put some ID shook to see the part of the ring is out or not. Thank you, ma'am.
So, Dr. Diptesh, it was a nicely managed case of zonal dialysis. I just want to ask, is it your own case? You've done it yourself?
Yeah, ma'am.
Okay, and voiceover has been given by someone else.
No, it is computer generated voice.
It is
I just type the words and it is
right.
generated.
So, can you tell me can you predict what patients have high chances of getting zonal dialysis during surgery? Can you predict it before surgery?
Yeah, if there is some
In what patients do you expect higher chances of zonal dialysis?
if we see the bag is weak, beforehand there is some movement of the lens.
Apart from phacodonosis, yes, any other?
Any there is pseudo exfoliation if there is, and hard cataract,
Thank
hypermature
you.
cataract.
Anyone wants to ask any question?
It, it is a ZD, not a PCR, and I intend to put the lens in the bag. Already CTR is stretching the bag. If I felt that bag is unstable, I would have gone for a CTS segment.
Now I would call on Dr. Harshvardhan Patil to present Harsha Nag, a new chopper in town. Dr. Harshvardhan Patil. Start the timer also, please.
Good morning, everybody. आवाज आवाज नहीं आ रहा.
So that the posterior plate is separated. Various choppers are available in the market like Nagaharas, Minardi, Dale, Siebel's, Claw, Chang, etc. But the most commonly used among all these is the Nagara chopper, which looks something like this. It has an inner cutting edge with a blunt tip. It's a long horizontal chopper. Most of us also use a long diagonal chopper with the inner cutting edge, which is sharp, pierces the nucleus easily. So let's see what are the difficulties with these choppers. Here I am using a Nagara chopper. I am piercing the substance of the hard cataract. Since there is a very little space between the nucleus and the capsule, it becomes very difficult to go to the equator and crack the posterior capsule. So there is an incomplete crack. So I rotate the nucleus and try from the other side. Here I get success to some extent, but here also the posterior plate is not cracked. So what happens if the posterior plate is not cracked? You may eat one or two small pieces, but the whole nucleus comes out of the bag like this. Yes. So there are high chances of damage to the endothelium if the posterior plate is not cracked. Let's see one more case. Here I am using a sharp diagonal chopper. Since it doesn't pierce the nucleus, it gives undue lower pressure on the nucleus. So there can be a nucleus drop. So it would be best if you have an instrument like this, an electric saw, which cuts the trees within seconds. So based on this idea, I took a long diagonal Chang's chopper of around 2 to 2.5 mm also you can use, and bend the tip of around 0.3 to 0.5 mm slightly towards the left side in the form of a sickle. So the sharpness of the chopper is also not lost, whereas you get a good lateral bend of the chopper. This is something how it looks like under the microscope. This is how it looks under the microscope. This is a titanium Harshnag chopper. So let's see how it works. Well, this is a grade 4 nucleus. I am embedding the phaco probe into the substance of the nucleus. Diagonally appears the nucleus. See how easily it pierces and gives a lateral suppression. This is grade 4 to grade 5 nucleus. I am embedding the substance of the nucleus with the Harshnag chopper, and see how easily it cracks within a single crack. Yes, so the posterior plate is separated here. You can see the red glow there. So I rotate the nucleus 180 degrees, repeat the same procedure onto the other side. See how nicely it separates. The posterior plate is fully separated. I divide these two big hard cataract nuclei into 4 quadrants. See again, you can see the red glow when you do the lateral separation. This amount of lateral separation you don't get with the normal straight chopper. Because of the lateral bend, you are getting this amount of lateral separation. So in hard cataracts, you can divide the nucleus into 8 or 12 small pieces. See, this is sub chopping of the. See, you can see this is total hard black cataract, grade 5 nucleus sclerosis. I embodied the phaco probe. See with the Harshnag chopper, what a good amount of lateral traction you get. You can see the red glow there. So nicely the pieces are separated. Similarly, I repeat the procedure onto the other side. Since once the posterior plate is cracked, then the case becomes very easy. I divide the nucleus, as I said, into 4 big parts, then subdivide it into 8 parts, and during emulsification you can again sub-chop it into multiple. There is no patency, no legal issues. Yes, it's not a chopper, it's an emotion. Thank you.
Thank you.
So very nice, innovative innovation you have shown of yours. What is the only disadvantage you find with this chopper?
Since it's a sharp chopper, there is no blunt at the tip. It can damage the posterior capsule if you are very deep enough.
So that is the.
But you are chopping it diagonally.
Yeah.
You are not going to the equator, so the chances are minimized with that.
So it's both ways. It's a
Yeah.
boon also and a bane also.
Yeah.
Thank you for
Thank
this.
you, madam. Thank you.
Anyone wants to ask? Now I would call upon Dr. Aarti Wankare.
Good morning, everyone. 4 quadrants sphincterotomy for a rigid non-elastic pupil.
Waiting for you.
When pupil size is reduced from fully dilated 9 mm to 3 mm, then surgeon's viewing area is reduced to quarter, which leads to vision-threatening complications. In order to achieve intraoperative pupillary mydriasis, various methods such as pharmacological mydriasis, viscomydriasis, iris-hook, stretch pupilloplasty, and pupil expanders have been tried. Video demonstrate novel technique of sphincterotomy by vitreous microscissors. This is a case 1. In this, as you can see, pupil is only 3 mm dilated. This is a case of glaucoma, status post trap surgery done. Cornea is also quite hazy, appears to be decompensated. So, in order to achieve pupillary mydriasis, we first performed synecholasis with the dialer. After that, we performed pharmacological mydriasis by the use of intracameral adrenaline. But both of the attempts failed to dilate the pupil. So, in order to dilate the pupil, we went ahead with the sphincterotomy. After achieving sufficient intraoperative mydriasis with the sphincterotomy, we proceeded with the phacoemulsification as in the usual cases. This is a case 2. So in this you can see pupil is only 2 mm dilated, and this is a case of chronic uveitis with occlusio pupillae. First we inflated the AC with the viscoelastic, and then we performed synocolysis as well as membranolysis, and after doing the synocolysis and the membranolysis all 360-degree, we tried to do pharmacological dilatation with the intracameral adrenaline, but our attempt failed. So in order to achieve pupillary mydriasis, we did sphincterotomies fashioned in the 4 quadrants, equally spaced, but as the iris was quite floppy, we make the use of the dialer. After achieving sufficient dilatation, we proceeded with phacoemulsification. This is a case 3 in which pupil is only 3 mm dilated. We first tried with the intracameral adrenaline, but pupil failed to dilate. Our next resort was performing 4 quadrant sphincterotomy. So we fashioned 2 side port in such a way that we made 4 sphincterotomy with vitreous microcisor equally spaced. Rest of the phacoemulsification was carried out in usual manner. An IOL was implanted into the capsular bag. These are the post-operative images of some of our patients who have undergone 4-quadrant sphincterotomy for the rigid, small, non-dilating pupil. So there is minimal distortion of the pupillary architecture post-operatively, as the sphincter tear were planned and predictable compared to the stretch pupilloplasty and other AIOCs and other pupil expanding devices. Additionally, pupil is almost round regular post dilatation, helping to serve the purpose of fundus examination in the post uveitic cases, and also reduce additional surgical cost of the devices and surgical time. Our take home message is intraoperative sphincterotomies with vitrectomy microscissors is safe and controlled method compared to stretch pupilloplasty in case of small non-elastic pupil. It achieves sufficient intraoperative mydriasis in comparison to the AIOCs and other pupil expanding devices. Additionally, it reduces the total surgical time.
Thank you for patient listening. Thank you, Dr. Aarti, for a nice presentation. And we all know that we do sphincterotomy with the other Caesars also. So, do you find it easy to do with? What do you want to
Ma'am,
convey after the speech?
generally we are using Vana scissor,
Yes.
but if you use vitreous micro scissors, those are lighter devices and they can be manipulated through the side ports also. We don't need the main incision, and so we can fashion it in a proper planned and predictable way compared to the Vana scissor.
You find it better and
Yes,
more
ma'am.
convenient to do.
Yes,
Okay. I will hand over this. Sir, want to ask anything?
Can you go for Malogene ring or BX ring in those cases?
sir. For the rigid non-elastic pupil, BHEX ring will require prior stretch pupilloplasty before introducing it. So first it will add to the time of the procedure. So we can directly go ahead with the sphincterotomy because it will not need other additional maneuvers like stretch pupilloplasty, and the sphincter tear caused by the vitreous microscissors will be planned and predictable. So permanent damage to the sphincter tears and permanently permanent sphincter atropies can be prevented, and post-operative glare and hollows and permanent dilated pupil can be prevented by this.
Thank you.
So now I would call upon Dr. F. Tarannum for slow motion video, dynamic videography.
Some motions are so fast that they are difficult to analyze. Time is in fact an arbitrary human made concept. While a second always takes place the same amount of time, the human internal clock is a metronome working at high variable velocities. A blink is 100 milliseconds. Pupil constricts in 200 milliseconds. The cover test, one of the most important tests for strabismus, appears simple but is actually complex. Eye shift in cover test takes place in 400 milliseconds. Slow motion to study fast moving objects was first invented by Dr. August and has been used in sports since long. In medicine, it was introduced in 2013. We used this technique for the cover test. We took video during cover test on Android phone. The video was transferred to you could download it from Play Store. The video was copied twice and speed of 0.5x and 0.3x applied to the second and third video. This video was then played and replayed on the media player. Here we can see the exoporia becomes more apparent in slow motion. We decided to do a pilot study. A group of trainees were shown the cover test. After that, video recording of the cover test was made, and the recording was then showed to them. They performed better by using this technique. A normal photography in this case shows left exotropia, but the slow motion shows poor fixation in left eye and loss of fixation when the cover is removed. Using this technique, we can assess and teach such fine aspects easily. Here we see small angle left esotropia with loss of fixation after some time. Here there is loss of fixation after a blink. Since we found this technique very useful to us, we decided to share this technique with the strabismologists over the world and get their opinion and feedback. They found the technique innovative and suggested we use it for DVD, DST and microtropia. They also suggested that we could use it for nystagmus and counseling of the squint patients. Slow motion dynamic videography of the cover test can be helpful in the detection and analysis of strabismus. It can also be used as a teaching tool for future generations.
Can you do prism cover test with the dynamic?
Yeah, we can do.
Do you have any video? Do you have any video? Extra video?
In next step, we'll. It is a starting phase. We did a pilot study. Then we can do another second set of studies with prism cover also. Yeah.
So, what is the limitation?
Limitation. I don't feel there is any. It is an additional thing. It is a future thing for this cover test.
Thank you.
Thank you. It was a nice one. I would call upon Dr. Abhijay Luthra for the next presentation.
Good morning, ma'am. Good morning, sir. Fixated iris claw lens from goat size to human. Speed बढ़ा देना वीडियो की 1.5x. So good morning. I'll be showing a video on basically that the importance. A very warm welcome to one and all. Today I, Dr. Abhijay Luthra, a DMB resident at Dr. Shroff's Charity Eye Hospital, will be talking about why all of us need to know how to implant an iris claw lens and how to go about training for that. So posterior capsular rents happen to everyone, and it's not always possible to salvage the bag or sulcus to be able to implant a PCOL. The usual technique that was used in these cases was to implant an ACIOL, but those come with their own set of complications. A ACD of at least 2.8 mm is required, a sufficient white-to-white distance is required, endothelial cell loss is known to occur post-operatively, and pupillary block chances are relatively high. This is where the iris claw lens comes in. Its advantages are the reduced chances of a pupillary block, no endothelial compromise, can be implanted in shallow anterior chambers, and there is no chance of any angle trauma occurring. The problem? They are not regularly implanted due to hesitance emerging from inexperience. So how did iris claw lens come to be? They were invented by the Dutch ophthalmologist Professor Jan Wurst in 1972, and initially the anterior fixated iris claw lens was invented. It was later modified by Brass and Neuhen as a retroic fixated iris claw lens. The usual indications are surgical aphakia with no zonular or capsular support, which can usually occur as a consequence of a cataract surgery complication, a lens dislocation, an IOL dislocation, or an IOL exchange procedure. What are the possible complications that can are iris tears, IOL drops, iridodialysis, and endothelial damage during implantation. Let us look at a couple of examples of how things can go wrong when trying to implant an iris claw lens without training. So in this case, it's a cataract surgery complication. There is no bag. The surgeon is trying to implant an iris claw lens. They go ahead with the iris claw holding forceps, try to enclave the first side. Just look how traumatic it is. There's already an iris tear and there's bleeding occurring from the iris into the anterior chamber. They go ahead and manage to implant the second side too, but there's again bleeding and both the sides have torn through the iris. Now they have managed to enclave the lens, but there are going to be high chances of post-operative inflammation in this case, and the iris anatomy has been hampered. Another example is showing how the lens was enclaved on one side, and after that the surgeon went ahead with enclavation on the other side, and they did manage to enclave it. That's what we think. We see a slight dimple which disappears as soon as they inject visco. The lens starts to sink into the vitreous cavity. This is where wet lab training for the iris claw lens comes in. So wet lab training for the iris claw lens initially starts with, it goes on pretty similar to how we train for SICS and phaco in the wet lab. First of all, we want to create a rhexis, and we'll go ahead with the regular SICS technique of delivering the nucleus. Create a well-sized capsular rhexis, which is fairly easy in a goat's eye, very similar to a human's eye. Go ahead with the sclerocorneal tunnel creation. As you'll see, I'm going ahead with the temporal approach because the pupillary diameter in the superior approach does not allow for a human-sized iris claw lens to be practiced in a goat's eye. So it's necessary to go ahead with the temporal approach. The tunnel has been created. Going to enter with the keratome, and the entry has been done. Going to hydroprolapse the nucleus into the anterior chamber and deliver it with viscoelastic. And now we can start with practicing our iris claw lens enclavation. So create a second side port. What's most important is that both the side ports have to be exactly diagonal to each other to be able to get an easy enclavation. They should have a small intracorneal length so that we have ease of access while implanting. Go ahead with practicing how to making a PI using a retractor. It can be done either superiorly or from under the iris depending on what the surgeon's approach is. And we go in and put in the iris claw lens into the anterior chamber. It's not necessary to align it exactly at this point, and we can go ahead and do that with the dialer. That's much easier since the chamber has more chances of staying formed at that time. Inject some viscoelastic under the lens, and then we go in with the iris claw holding forceps and the enclaver. It's necessary that we hold the iris claw lens exactly in its center so that our enclavation site is in the correct place. Go in and enclave it from one side, reform the anterior chamber with viscoelastic, go in again, hold it in the center and enclave it from the other side. A slight tug ensures that the iris claw lens is well enclaved and it's not going to drop behind once we're out. So once again, viscoelastic is injected and it's checked that the lens is in place. This is our wet lab training. A slight tap will also ensure that it is in place. So this is where the retrofixated iris claw lens comes in. It's the saving grace. The background of the slide represents what every resident is thinking as soon as they have a posterior capsular rent in the operation theatre. Our biggest fear, aphakia. can be saved with the help of iris claw lens. So now this is a video of how a well-trained surgeon can easily use an iris claw lens to save the day. This is a case of a dislocated IOL. We don't know whether that's due to any post-operative trauma or whether the primary surgery was finished in this way itself. So going ahead, the surgeon makes a side port, dials out the lens into the anterior chamber, and following this, makes an entry into the anterior chamber, pulls out the lens very atraumatically, sutures up the main section before going ahead with the vitrectomy. It's very important to clear all the vitreous from the anterior chamber, as that can lead to traction on the IOL. A superior PI has been made. The iris claw lens is put into the AC, dialed into the place after that using a dialer. Going in, the lens is held exactly in the center with the iris claw holding forceps enclaved on one side. Chamber is formed again with viscoelastic, and going in again, the lens is enclaved on the other side. And the lens is well enclaved. We'll just be pushing it back into the posterior chamber using viscoelastic very atraumatically, and that's a very well done iris claw lens, which should probably give the patient a good vision for a lifetime. Important points to be kept in mind are that make the side ports with short intracorneal tunnels for ease of access, do a good anterior vitrectomy, side ports should be diagonally opposite to each other, the tip of the forceps should align with the notch on the haptics, and a make a PI always to prevent pupillary block. The possible contraindications are recurrent iritis, severe iris atrophy or tissue loss, uncontrolled chronic glaucoma, or corneal dystrophy or degeneration as endothelium is already compromised. IOL power can be calculated usually through the SRKT formula, or the A constant value of whatever lens you are using has to be put in. For us, it's usually 117.2. This is a study showing the visual outcomes of the iris claw lens implantation in patients. The difference between the pre-op and post-op visual acuity is significant in all cases, and the difference in the IOP is not significant in any of the cases. Hence, we know that it does not lead to too much of an IOP increase. A good surgeon is one who has minimal complications, and an even better surgeon is one who manages its complications well. Thank you.
How do you achieve centration?
Sorry, sir.
While using iris claw lens, how do you achieve centration?
So centration is basically what's important is that our two side ports should be exactly opposite each other, and I've seen that a lot of times people also avoid using the main side, the previously made side port, because the side port we usually use for the rexes and throughout the surgery has a slightly longer intracorneal length. So for the lens implantation, they suggest that make one with as short of an intracorneal length as possible and exactly opposite to each other. And the next important thing is that once you go in with the forceps to hold it, so your forceps should reach till at least half of the iris claw lens, because if you hold only the initial half, the chances are that when once you're trying to enclave it, it will probably tilt or slightly rotate. But if you've gone past the half point while you're holding it, then the maximum chances are that it will stay in place.
But there are still chances of slight movement of the lens.
Yes, ma'am.
And
Those are always
you rightly said it's better to retrofixate the IOL, iris IOL, but then you were talking about iris atrophy and all. So it obviously you will be doing it in a complicated eye. And
yes, ma'am.
so any thing related to the status of iris you want to suggest, whether you should go for retrofixation or
so ma'am, if our iris is compromised, if there are iris tears, then we may not be able to implant it. Basically, I have seen that people have implanted it if just their nasal and temporal iris is intact, and even if the superior and inferior tissue is lost, they have still managed to go ahead and the IOL has stuck in place. But yeah, if our nasal and temporal iris is not intact, then it would be better to maybe go for a scleral fixated or other way of.
Okay, thank you, Dr. Abhijit. It was a nice presentation.
Thank you, ma'am.
May I comment?
Yes.
Iris claw lens introduction should not be done without naming late Dr. Gurjeet Singh. Please. He only.
Yes.
Now I would like to call upon Dr. Ayushi Agarwal, surgical techniques to manage post-trabeculectomy hypotony. Dr. Ayushi. So the next is Dr. Apurva Nagtode. Dr. Apurva not there. Then Dr. Kusumita B. Dr. Kusumita not present. Dr. Smita Narayan. So ma'am is here to present affordable MIGS training and surgery.
Good morning, dear judges, and good morning, audience. Here's my presentation. Two mixed procedures so that surgeons can add them to their repertoire with minimum complications. Davinder Grover of the Glaucoma Associates of Texas was the first to describe suture GAT. A practice eye, already used for phaco training, is dismantled. A leftover silicon tube of a DCR intubation set with an inner diameter of 0.3 mm is glued to its surface, leaving a gap between the two ends. The leading end of a 6 cm long 50 proline bit is passed through the side port. 25 gauge microforceps introduced through the main wound helps to thread the proline into one of the cut ends of the silicon tube. The surgeon can undergo any number of training sessions with this model. The practice of GAT is achieved by performing a large number of office gonioscopies. Next, the surgeon practices observing the angles using the Swan-Jacob gonio lens. On transitioning to a real surgery, the anterior chamber is filled with a higher end OVD. The gonio lens is positioned. A 25 gauge MVR blade is used to nick open the Schlemm's canal. Heat cautery is used to blunt the proline tip into a mushroom. It is then introduced through the side port towards the nasal angle. Once the leading tip has reached the initial point, both ends of proline are held and pulled, effecting a trabeculotomy. Hyphema is the commonest complication, which can be minimized by retaining 30% of the OVD. The second mixed procedure is BANG, where a 25 gauge needle is modified for ab interno goniotomy. Here we describe how to fashion a 32 gauge needle to mimic the dimensions of the Kahug dual blade. A 32 gauge insulin needle is separated from its hub. It is then swaged into a 25 gauge needle, crimped, and the tip is bent towards the bevel. The patient and the microscope are positioned as described for GAT. The modified needle blade is introduced into the eye and the inner border of Schlemm's canal with the trabecular meshwork is removed for 5 clock. It is worthwhile to remember that identifying the trabecular meshwork intraoperatively is the most important part of both the procedures. It can be identified by number 1, recognizing the pigment of the angle. 2. Blood-filled Schlemm's canal when the eye is hypotenuse. And 3, and most useful, is the blue staining of the trabecular meshwork with trypan blue.
Next, I would call upon Dr. Tejas Atnur. Not present. Dr. Tejas. And then last but not the least, Dr. Anup Singh. Very interesting topic, escaping through the wind and working behind the walls. Let's see what he has to say.
Presence of large corneal opacity area poses challenge to the best surgeons. Adherence along with posterior synechiae in a case complicate the case. Use of adrenaline will come to help for dilating the restricted pupil after releasing the synechiae. And also adherent glaucoma should be released in order to make the iris free from the wound. Many times we will see the iris being myosed, which are either being mechanically dilated using viscoelastics or can be dilated using sphincterotomies. The free edges poses threat to a later done cataract surgery by repeatedly keep on coming to the probe. So the edges can be trimmed using cutter from the anterior vitrectomy. Aim is to attain a nice circular pupil. A larger area of visualization of the lens will help during the time of capsular access. Again, challenge being guiding the axis underneath the corneal opacity, and the key is to maintain a good anterior chamber volume to prevent peripheral runoff. A good hydrodissection will ensure the nucleus coming out of the bag. Since our view is limited here, aim will be to segment our emulsification in various parts and keep the machine setting low. You have to stop in between to mechanically put viscoelastic and push the iris tags periphery. Use of viscoelastic should be done amply. Bag is then inflated using viscoelastics, and cortical aspiration again became difficult in the portion which lies underneath the corneal opacity area. Swift, gentle movement of the tip needs to be done in order to avoid catching up the excess margin and further complicate the surgery. Lens is being implanted and dialed and confirmed being inside the bag, and case is being closed. Key to surgery is to keep patience.
Thank you so much.
What was the post-operative vision?
Vision was 624, pre-operative was 3/60.
So it was a case of post-traumatic?
Post-traumatic.
Traumatic, okay. So how diligent you have to with the hydro delineation as you were telling?
If our excess margin is intact, we know the size and location and somewhat about the condition underneath the corneal opacity portion. If there is no adherence or there is no pre-existing zonular weakness or any vitreous disturbance in that particular area secondary to trauma, then we can be sure for the hydrodissection. We can go as we do in routine cataract surgery. If there is zonular dialysis or adherence, or even if the things which are not very clear pre-operatively, then we have to be little bit gentle, go either with the hydro, or we can do even the visco dissection, dial up the nucleus into the anterior chamber, and by rest of the surgery can be completed as usual.
Okay, thank you, Dr. Anoop. So
Thank you so
I
much.
conclude this session, and thank you all. All the presentations were very informative.